One and all, on behalf of IPS South Zone Women Empowerment Committee, Samanwi, I, Dr. Veda, convener, I extend a warm welcome to our own Dr. TSS Rao, sir, IPS President-elect, Dr. Abhay Matkar, sir, our immediate past President, South Zone, current IPS South Zone office bearers, Dr. Uma Shankar, our President, Dr. Arul Prakash, Vice President-elect, Dr. George Reddy, our Honorary General Secretary, Dr. Mahesh Gowda, Dr. Rajshekar sir, IPS South Zone members, esteemed speaker Dr. Anita Rairala, and our chairperson Dr. D. Vijay Lakshmi Madam and Dr. Shivaraman for today's webinar. Today we're going to discuss an important topic on domestic violence and mental health, legal and therapeutic intersections. So without further delay, I request Dr. George Reddy, our Honorary General Secretary, to give his opening remarks.
Thank you, Dr. Veda. At the outset, respected President, Dr. Uma Shankar sir, Dr. Arul Prakash sir, Vice President, Dr. Mahesh Gowda, Dr. Rajshekar sir, our immediate past President, Dr. Abhay Matkar, and dear Dr. Lokeshwar Reddy, organizing the chair for the committee, Dr. Uma Jyoti Madam, and Veda, Nivedita, LC, all the members. This is a wonderful activity. I think it's the second of its activity. And today's topic, domestic violence and mental health, legal and therapeutic intersection. I think we cannot imagine any other better speaker than Dr. Anita Rairala. I think when we look at domestic violence and mental health, I think it will be more related to the female gender. But somewhere in my clinical practice, I see the male are also the victims and having these kind of mental issues related to domestic violence. Without much time in between, I think it's a wonderful activity from the Samanwi committee. And Veda, I think you're doing a wonderful job, and keep this up. We will expect another 3-4 from this committee before we end for the this year. Thank you, Dr. Veda.
Thank you, George sir, for your kind words. May I now request Dr. Uma Shankar sir, President South Zone, for a few words to address the gathering.
Good evening.
Uma Shankar sir.
Good evening, all of you. Dear IPS South Zone office bearers, President-elect Dr. Arun Prakash sir, and Secretary George Reddy, Treasurer Dr. Mahesh Gowda, Editor Dr. Rajshekar Baipeta, immediate past President Dr. Abhay Matkar, General Secretary Dr. Lokeshwar Reddy, and immediate past Editor Dr. Shaul Amin, and Treasurer Arun Kumar, and our senior faculty, senior member, and also President-elect Dr. TSS Rao, and Samanwi committee members, Chairperson Dr. Uma Jyoti, and Co-Chairperson Dr. Nivedita, and LC Women, and convener Dr. Veda, and Dr. Advisors Dr. Arun Yadilal, and Dr. Indumati, and member Abhirami, and today's important persons, speakers. Today's speaker, Dr. Anita Railala, and she is a professor and superintendent of Institute of Mental Health, and chairpersons to Dr. Shivaraman is a professor and head department of Psychiatry, SRM Medical College and Research Center from Chennai, and Dr. Trichy, and Dr. Vijay Lakshmi, professor and head department of Psychiatry, JHMC, AMC Vizag. And it is my privilege to welcome you all, the members, and as well as today's participants. And it is an important webinar for all of us, not only women, it is all of us, to help the society how we learn some of the things, legal and also mental health issues. And during this webinar, the webinar on domestic violence and mental health, legal and therapeutic intersection. Today we will explore the complex relationship between domestic violence, mental health, and the law. Now Dr. Anita, she is also not only mental health professional, now she is doing her law profession also. Definitely this law course may be helping us. And also today's our goal is to equip all of us with the latest knowledge and tools and the strategies to better support supervising and the victims and their families. With this, I thank the organizers and speaker as well as chairpersons for accepting the chairing and also as a speaker. Importantly, the Samanwi committee. I thank the Samanwi committee organizing this important thing, and I thank everybody with giving this opportunity also. Thank you.
Thank you, Dr. Umashankar sir, for your kind words and insights on the topic. May I now request Dr. Uma Jyoti, Madam, Chairperson of Samanvi Committee, to kindly introduce the topic for the webinar.
Good evening all. On behalf of our committee of John Samanwi, I welcome you all. I welcome Dr. T.S. Am I audible? Effects on a person's mental health. The intersection of therapeutic legal aspects is crucial in addressing this issue. And today's speaker, Dr. Anita Rayala, is the most suitable speaker for this topic, as she is dealing as the superintendent of IMH Hyderabad, and also she is the CEO of State Mental Health Authority. I welcome all, and I request Veda to continue.
Thank you, Madam. May I now request Dr. Nivedita to kindly introduce our speaker, Dr. Anita Rairala.
Sure, Veda. Thank you so
Yeah.
much. Am I audible?
Yes, ma'am.
Yeah. So it is definitely my privilege to introduce my sister and my friend, Dr. Professor Anita Rairala. It feels really proud to say that she is now the Superintendent of Institute of Mental Health, Hyderabad. She is Member Secretary, CEO, Mental Health Authority of Telangana State. Everybody has said this, but I definitely take this out again as a pride because she is doing such a wonderful job. She has 16 years of experience as in the teaching profession, and all her UG and PG students simply like her. I think I give the first-hand information because I interact with her PGs as well. And she has about more than 15 publications to her credit so far, and she has guided many PGs and students in their thesis and other topics. She is a recipient of Podu Channareddy and Venkat Ramamma award in the state conference for consultant paper, best consultant paper category, not just once, but 2 times, 2018 and 2022 again. Apart from this, her administrative and teaching roles, she is a wonderful psychiatrist, and she has contributed a lot for the mental health awareness. Her interviews in papers and TV in the local channels, she has a very simple and subtle way of putting her point across, which is very effective. I congratulate her for all the work that she is putting together. And apart from that, she has been the vice president of HPS, and she's currently serving as a treasurer of IPS TSB. It is my privilege to welcome you and thank you for accepting to be the speaker for today's topic. I think you are the right and the apt speaker for today's topic. I'm looking forward to a great session. Thank you, Veda.
Thank you, Dr. Nivedita, Madam, for the kind introduction. May I now request Dr. Aruna Yadial, Madam, to introduce the chairpersons for today's webinar, Dr. D. Vijay Lakshmi and Dr. Shivaraman, sir.
Thank you, Veda. I consider it my privilege and honor to introduce our esteemed chairs for today. First, I would like to introduce Dr. S. Shivaraman. He is currently professor and HOD in Trichy SRM Medical College in Tamil Nadu. He is also a proud alumni of AIMS Delhi with more than 15 years of experience in PG teaching. He has also held very important positions in IPS, like being the convener of mind-body mechanism or spirituality and mental health. He is also currently chairperson of Tamil Nadu IPS RCBC committee. He has also published an article on intimate partner violence in keeping with the theme of today's theme among spouses of patients with alcohol dependence syndrome, and is guiding a thesis which is on similar lines as well. We welcome you, sir, to the session. Our second chair is also a very distinguished person, Dr. D. Vijayalakshmi, who has done her MBBS and post-graduation in Andhra Medical College, Visakhapatnam. She has worked in Visakha Steel General Hospital, RINL, from 1994 to 2005. And thereafter, she has worked for the Andhra Pradesh state government under Directorate of Medical Education in various cadres. Currently, she is working as professor and head of the department in Department of Psychiatry, Andhra Pradesh Medical College and Government Hospital for Mental Care at Visakhapatnam. We welcome you to the session, sir.
Thank you, Dr. Aruna, ma'am. May I now request Dr. Vijay Lakshmi, madam, to kindly give her opening remarks for the webinar.
Thank you, Dr. Aruna, for the kind introduction. Very good evening to all the organizers and all the participants. First of all, let me extend my thanks and warm regards to the members of Executive Council of IPS South Zone. I had the privilege of meeting most of them last month when we had the annual PG training program. So you were all there. I'm very happy to see you all again. Our President, Dr. Uma Shankar Garu, Honorary Secretary, George Reddy Garu, Editor Rajshekhar Garu. And that is where, for the first time, I met our dynamic speaker today, Dr. Aruna. And I thank the Samanwi committee for giving me this opportunity to chair this session. And particularly Dr. Veda and Dr. Uma Jyoti madam, who have approached me today to chair this session along with Dr. Shivaraman sir. This domestic violence and mental health, legal and therapeutic intersection. It is a day-to-day practice what we are seeing in our hospital almost on a daily basis, because we happen to have a forensic ward. And the domestic violence, as you all know, it is a multifaceted thing. There are no boundaries, geographical or economic or social. Every woman of every strata, everybody is affected, and even small children are also sometimes targeted. Only 2 days back, we had this 19th of July, we saw a video where a man was, holding his young child, 8-month-old boy, by his feet and, parading through the village. That small kid had a dislocated hip subsequently. This is a dowry harassment. It is such a pathetic thing that woman who is entitled to safety, security within the 4 walls of her home, there itself, if she is undergoing this cruelty and has to endure this violence, this is high time it should stop. And it is there everywhere, and our country is no exception. So definitely steps must be taken to stop it. I mean, we should have no tolerance for this. And we had this 498A section. In 1984, it is incorporated in IPC. But even then, we had to have a Domestic Violence Act in 2005. It is supposed to be enforced from 2006. But still, the crimes are going on as usual. And it is so shocking that society is so permissible. I mean, everybody, it is so normalized by everyone, and sometimes even by the victims themselves. They say like it is a usual practice to have that kind of violence. And it is associated with so many things, mental illness, substance abuse, or simply greed to get money from the woman. Okay, to some extent, maybe men are also subjected to violence, but that is a very minimal numbers. And like all of you, I am also eager to hear Dr. Anita's take on this, because she's leading a hospital which has almost double the strength of our hospital. And if we are seeing so many cases on a daily basis, I can go on giving examples. Yesterday, day before yesterday, every day we have these cases. So she must have seen quite a lot. And as somebody said, she's doing her law also, I think. So I'm all ears to listen to her speak. Thank you.
Thank you, Dr. Vijay Lakshmi Madam, for the insights and the opening remarks. May I now call upon Dr. Anita, our esteemed speaker, to share her insights on the topic. Over to you, Dr. Anita.
Good evening, everyone. Am I audible? Thank you for this wonderful privilege for me to to receive this opportunity from Samanwi, and I feel very privileged to thank everyone, particularly IPS President-elect Dr. TSS Rao sir, and IPS South Zone President Dr. Umashankar sir, the Secretary Dr. George Reddy, and Editor Dr. Rashekar sir, and my executive council members of Samanwi, and my chairpersons Dr. Shivraman and Dr. Vijayalakshmi Madam, and Nivedita for her kind introduction, and all the members who are attending this forum today. I feel very privileged because this is the first time I'm speaking on this platform, and in the presence of so much of intelligent people around me, it's very challenging for me to take this topic. Into the topic, I would like to share a small case vignette. I was sitting in OPD one day, and I saw one patient who is very young, around 23 to 25-year-old. She was waiting in the corridor along with the police escorts. I was actually puzzled to see her because she looked very naive and innocent, and she was looking very sad and depressed. So immediately I called into my room, and I started examining her. And on MSC, I could find that she's severely depressed. And when I asked her what made her to be in the prison, she was actually referred from the prison authorities for evaluation and also for certification. So when I interviewed her, she said that she's a victim of domestic violence. She said that she was having the harassment from her husband from since a long time, even before the child was born. Then she got conceived and she delivered a male baby. She thought at least after the delivery, he would see her properly and take care of her. But instead of that, he started being more abusive. So after 9 months, the baby had grown to 9 months of age. Then she had an opportunity to come back to her paternal family, and without 1 or 2 days she spent with the family, and after that she took overdosage of sleeping pills, and then she throttled the baby and killed the 9 months old male child, and then she fell unconscious. Unfortunately, she was saved by the family members and she was put in hospital, but eventually she was caught by the police for killing the baby and she was kept in the prison. This was a sad story of victim of domestic violence, and I wanted to counsel her and asked her why did she take that extreme step. It was so shocking. I asked her, there are so many remedies available, so many options available. You could have taken a divorce, or you could have lodged a criminal complaint against your husband. Why did you take this extreme step? She told me that I don't know, madam, at that point of time I was too depressed, and nothing came into my mind. I just wanted to kill myself, and I thought who would take care of my baby when I die. So I killed him and I wanted to die. So this was the sad state of affairs. She never know she never knew what the options she was having, what protections that she was having, and she never thought of them. So this is the sad story of a very young female. Now she's landed up in prison. She lost the baby, she lost the family, she lost everything. So keeping that in mind, the domestic violence cases are very high, and being a psychiatrist, we have to be well aware of the victims of the domestic violence and what we need to do and how to go about it. So my presentation is basically about this. My plan of presentation is like I'll be talking a little bit about domestic violence and the definitions and the types, and a little bit of statistics and the mental health issues associated with domestic violence and the management. And also about so domestic violence was not introduced as the domestic violence term was not used in IPC. It was used like cruelty. 498A talks about the cruelty of the husband towards husband or in-laws towards the wife. This is the term used. This will be talked. This will be explained in section 498A, and the punishment awarded will be given in the IPC section 498A. So it had become very, very famous in the recent years. Many people were complaining and putting a section of 498A on the husbands whenever there is a incident of domestic violence. And then came an act which is specifically addressing the domestic violence, because this 498A is addressing the cruelty, not the comprehensive problems of domestic violence, and it is not addressing giving proper remedies. So there came a new act, which is Domestic Violence Act, which came in 2005. And domestic violence is a broader term, and intimate partner violence is a part of domestic violence. So when we understand domestic violence, it is not only directed towards a wife. It can be directed towards any member, any female member of the family in the domestic area. Say, for example, a daughter or a daughter-in-law or a mother-in-law or any person for that matter who are sharing the same domestic space. They can be considered as having domestic violence. But most of the times it is only like wives are more commonly affected. That is the reason why we think that domestic violence is only towards a wife or a partner, but it is not so, because domestic violence act wanted to cover all the females who are living in the same domestic space. And violence can affect women's physical, mental, sexual, and reproductive health, and also increase the risk of HIV. And violence against women is preventable. It is very much preventable. And the health sector particularly has an important role to play for this and provide comprehensive health care and as an entry point for referring women to other support services. So sometimes, as we know, when we sit in the OPD, we will be the first in the pathway of the care. They must have not informed anyone. You may be the first person who was listening to the domestic violence. Then coming, what is the definition of domestic violence? There are 4 points given in this definitions, different types of there are different criteria. One is omission or commission. It can be an omission or it can be a commission or conduct. What is that conduct? Harms or injures or endangers the health, safety, life, limb, well-being, whether mental or physical, of the aggrieved person, and includes causing physical abuse, sexual abuse, verbal, emotional abuse, and economic abuse. So when we talk about domestic violence, it's not just physical violence. There are different perspectives to that. There are different kinds of violences. And the second point would be harasses, harms, injures, endangers the aggrieved person with a view to coerce her or any other person related to her to meet an unlawful demand for any dowry. So particularly if they are targeting the women for the dowry, it also comes under domestic violence. And effect of threatening the aggrieved person or any person related to her by any conduct, threatening behavior, trying to throttle her, kill her, or any kind of threatening behavior can come under domestic violence. And otherwise injures or causes harm, whether physical or mental, to the aggrieved person. So quite often people report about the physical violence, but they don't report about the mental violence, because you can't have any evidence for that to show to the public or to the family. So most often it is only the physical violence which is often reported. So coming to the types of domestic violence, there are basically 5 types. One is physical, psychological, financial, sexual, and verbal. And these are different perspectives of domestic violence. And giving the examples, if you want to see, the physical violence is like shaking, smacking, starving, genital mutilation. See how weird it is, like genital mutilation and using objects as weapons. So these come under physical violence. Then comes sexual violence. It is forced sex. This comes under sexual violence. We don't have a marital rape concept, and it is not considered to be illegal, but still forced sex with wife can be a sexual violence. And forced prostitution, making the wife or a partner to go for prostitution, and ignoring religious prohibitions about sex. In some religions, some particular types of sex is avoided, but still, like oral genitalia, putting genitals in the oral cavity, all these are prohibited in some religions, but still they stick on to force the partner to do this. And refusal to practice safe sex, that's how HIV gets, the women can get contaminated. And sexual insults or preventing breastfeeding. This is very, I was surprised to see this. Even people prevent breastfeeding also. And the psychological injury, like psychological abuse, is like intimidating, insulting, criticizing, isolating person from friends and family. So this is very commonly seen in Indian context, where the wife will not be allowed to meet her parents or talk to them over phone. So this kind of behavior is commonly seen in our setup. And treating a person as an inferior, you good for nothing, you don't know anything, waste fellow, these kind of abuses amounts to psychological abuse. And financial, like not letting the person to work, or undermining efforts to find work, or asking for how you have spent the money, or not giving even for daily needs, or for basic needs also not supplying money, comes under financial abuse. And then comes emotional or verbal abuse, and swearing, undermining confidence, making person feel unattractive. So all these kinds of abuse, different kinds of abuse we come across. And if you see the global burden, violence against women, particularly intimate partner violence and sexual violence, is a major public health problem and a violation of women's human rights. And globally, about 1 in 3, 30% of women worldwide have been subjected to either physical or sexual. These are the only common things which are commonly reported, because the other kinds of violence is not even reported. And most of this violence is intimate partner violence. And almost 27% of women are aged between 15 to 49 years. 27% of women aged between 15 to 49 years who have been in a relationship report that they have been subjected to some form of physical or sexual violence. So this is almost 30%. And if you see the worldwide data, this red one is around, this India, around 35% of Indians are reported to be having domestic violence. Coming to the crimes against women, there are different kinds of crimes against women, like kidnapping or outraging the modesty, rape, and the most common one is cruelty by husbands or his relatives. It is almost 27.9%, that is around 30%, which is considered to be highest. So it is not about the people who are doing crimes, the outside people. It is the inside people which are more dangerous. It looks like from the statistics that the home is not a very safe place. And if you see the domestic violence and women's health, and most is like moderately harassment of married women, and dowry harassment is also quite high. And types of domestic violence, it is not studied in India, but it was studied in Saudi Arabia. So the most common kind of domestic violence is, if you can see, psychological violence is the most common. Around 48.4% is the psychological violence. So we psychiatrists are having a big role in that. And physical is 34.77%. This kind of studies are not done in India. I think somebody can take up like what kind of domestic violence is more commonly seen in India. And other studies research have shown that for most sexually abusive married women, husband was the perpetrator. In 82% of cases, it is the current husband who is the perpetrator. So we can see like how much is the burden, and how safe are the families, how safe is the husband, and 13.7% from the former husband. So these are the two categories which are considered to most, abusing females. And from 2010 to 2019, National Crime Records Bureau, the numbers are increasing, and 38% of all murdered women, in contrast to 6% of all murdered men, are killed by intimate partners. Nowadays, we are seeing in the news that many females are killing husbands and murdering them or all that. But if you see the statistics, 38% of all murdered women are killed by intimate partners. This is very high. So, and this is a study done by me in around 2018. Around 2018, I have interviewed 100 homicidal offenders. This is a study done in Chanchalguda and Challapalli prison, where I have interviewed 100 homicide offenders. So if we see the victim characteristics, 61.7% are the females only. So out of 100 murders happened, 61.7% were against females, and family members contributed 60% and spouse 30%. So out of 100 murders, 30% murders are towards the spouse. So this is very glaring and very shocking to know that it is done by the husband. And coming to the National Crime Records Bureau 2020, 1 woman died per hour in India because of dowry in 2019, and 4 women were raped every hour in India. And 14 cases have been registered under cruelty by husband every hour. It is high, very high. And coming to the risk factors, there are different kinds of risk factors which was studied in among many papers have given the same kind of risk factors, so have compiled some kinds of risk factors. And if you see the intra-individual risk factors, that is the factor which is there in the individual. Example, excessive drinking or personality disorders or biological or neurophysiological disorders. And the victims, the risky victims are who are young and females, quite obvious, and who are not having a supportive family, having a disability of mental or physical ill health. If we see our patients also, when they get admitted in our hospitals, particularly borderline personality patients of depression, we see quite often they say that they have domestic violence at their houses. So having a physical illness or a mental illness is a risk factor in the victim. And aggressive behavior of the victim or social isolation, relationship dissatisfaction, substance abuse in the victims are all risk factors. And perpetrator risk factors are characteristic traits like insecurity, low self-esteem, low empathy, low impulse control, and poor communication skills, poor social skills. All these are factors, risk factors in the offender. And personality styles like aggressive and hostile personalities, antisocial, and who abuse drugs and alcohol dependence are more prone to commit domestic violence. And gender role expectations and masculine ideologies and sense of entitlement. They say that they're all powerful. They think they want to exert control on human beings. This kind of, gender role expectations are high risk factors. And socio-psychological risk factors like social learning, exposure to violence in the family when grows up, it is also a risk factor. And the victim risk factors are childhood physical or sexual abuse, and witnessing domestic violence in childhood is a risk factor for the victims. And the same thing like childhood sexual abuse and family violence is a risk factor for the offender too. And occasion different situations in life like pregnancy, current or imminent separation or divorce, and child contact disputes. All these are risk factors. Like pregnancy is a risk factor and separation is a risk factor. That's the reason why many of the domestic violence cases occur even after separation. And sometimes child custody disputes, all this have effect. And perpetrator characteristics like loss of job is also a risk factor. And perpetrator characteristics are like physical, they have what tendency, I said that this is one of the biggest risk factor. People who are having a tendency to control or exert power on others are highly risky. Like they use techniques like, how can you identify people who are having this kind of tendency? Like they use intimidation, they use emotional abuse, they use isolation, like controlling the victim and not allowing them to go outside or interact with others. and minimizing and denying and blaming, using children, talking about the physical, the power and control exerted by the offenders. So how to identify them? One is they use intimidation, and they use coercion and threats and economic abuse, using male privilege, using children to blackmail females, and also minimizing, denying and blaming kind of tendencies. So these are the characteristics of the offenders which exert power and control. There is a strong evidence linking alcohol also with domestic abuse or domestic violence. And in the USA, 40% of the reported domestic violence has the alcohol factor present during the offense. And alcohol consumption is more related to the severity of the domestic violence. So if you see the perpetrator's history, many cases are because of the alcoholism. And if you see the victim's characteristics, people with severe mental illnesses are at increased risk. People with severe mental illnesses are increased risk of becoming victims of the domestic violence, like borderline personality disorder or mental retardation and substance use disorders. These individuals are more prone for domestic violence. And one systematic review and meta-analysis of 42 published studies said that domestic victimization in psychiatric patients found a more prevalence of lifetime partner violence of 30% among compared patients. And the family risk factors like severe family dependency or disempowerment, and families with the parental incapacity like psychological, intellectual, parental illnesses, and control of severe family dependency or disempowerment, and parental incapacity like psychological, intellectual problems in parents, and control of wealth and decision making within the family centered on one partner, most often the male, or one or both caregivers abuse substances of any kind. If these conditions are present in the family, in those families also domestic violence is considered to be high. And coming to the cycle of abuse, there is in most of the patients there will be this kind of cycle which is seen, like tension. The first stage there will be tensions building up. Tensions increase, communication breaks down, and victim becomes fearful and feels the need to placate the abuser. Then comes the incident, which is a verbal, emotional, or physical abuse or anger, blaming, arguing, threats, and intimidation. This is the second stage. After the stage, when this injury happens, after this abuse happens, then there is a stage of reconciliation where the person become very soft and very quiet and peaceful and starts reconciling with the partner. So this is considered to be a honeymoon phase where the wife feels or the partner feels very, very happy and thinks that the things are moving in a right direction, like that. But this calm phase, the fourth phase, is a calm down phase, and after that again the cycle repeats. So what is the impact of intimate partner violence? One is physical trauma like injuries, and then psychological trauma like mental problems like PTSD and anxiety, depression, eating disorders. All these are very common in IPV. And substance abuse like alcohol and other drugs, and non-communicable diseases like cardiovascular diseases, and somatoform diseases are very commonly seen. And then fear and control in the victim, like limited sexual and reproductive control, and prenatal or maternal health, there will be perinatal and maternal health impairment, like causing low birth weight babies and prematurity and pregnancy victims. And healthcare seeking behaviors like lack of autonomy and difficulty seeking care and other services. So they don't usually come for care. And sexual and reproductive health will also be impaired, like unwanted pregnancies are common, abortions, HIV, and other sexually transmitted diseases are very commonly seen. And also this physical trauma and psychological trauma can lead to disabilities and also sometimes to death by homicide. The partner might kill the victim, or it can lead to suicide. The victim kills herself. So this can be the ultimate, the impact of intimate partner violence. So what are the mental health issues in victims of domestic violence? The most important thing is mental health can also be a consequence of victimization. It can be a forerunner, or sometimes it can be a consequence. And the most important disorder which is seen in this domestic violence is PTSD. About 55 to 92% patients of victims will complain of PTSD, followed by depression and substance use disorders, anxiety, and then suicide. Suicide, 3 out of 10 women who undergo domestic violence are likely to attempt suicide. And women who experience IPV, particularly sexual abuse, are at risk of suicidal ideation or behavior. And women are by 7 times more likely to report current suicidal ideation than their counterparts who had not experienced IPV. So this is very risky. Suicide is more common, and compared to other individuals who don't have domestic violence as the risk factor. So coming to the PTSD, what you see is different from the normal PTSD we see. Usually in post-traumatic stress disorder, they will have a major event like rape, or one single disastrous event will be there. But in complex PTSD, it is basically because of multiple repeated harassments or multiple repeated traumas which lead to complex PTSD. So what is the difference between the simple PTSD and the complex PTSD? In complex PTSD, in fact, along with the symptoms of avoidance, hyperarousal, and flashback phenomenon, there will be other symptoms like difficulty to regulate emotions. This is one of the most common symptom we see in complex PTSD. That is like self-harm, rage, frustration, and becoming very angry. All these are because of difficulty to regulate emotions. And then altered attention and consciousness. This is dissociative amnesia kind of a thing, which is also seen in complex PTSD. And difficulty in maintaining relationships, like they become withdraw. They don't speak to anyone, they just be in their own world, and they be helpless. So these are the main symptoms, core symptoms seen in complex PTSD, apart from the regular symptoms of PTSD. So this complex PTSD may develop following exposure to an event or series of events of an extremely threatening or horrific nature, commonly prolonged or repetitive. This domestic violence is definitely repetitive, for which escape is difficult or impossible. They have to be in the same area, they have to be in the same house, and they have to have repeated these kind of horrific, threatening experiences. So that is the reason why they develop complex PTSD, such as torture, slavery, genocide campaigns. They are equivalent to domestic violence. So the key differences between PTSD and complex PTSD is, in PTSD, we have 3 core symptoms like hyperarousal and flashback phenomenon, nightmares. All these are there in simple PTSD. In complex PTSD, we have additional emotional dysregulation and withdrawing behavior. So how do we manage these? What are the legal things which we need to manage, and the psychological things? And the legal protection against domestic violence, there are some laws which are very much needed to be known by all of us, because there are some remedies available for domestic violence. So the laws which are very important are Dowry Prohibition Act, because one of the most common reasons for domestic violence is dowry harassment. And we also need to know about the cruelty towards the cruelty of husband towards wife. This also is a punishment given for husbands who are very violent towards the wives. I'm still, we have transformed into Bharatiya Nyaya Samhita, but to avoid confusion, I'm still, because we are in the state of transition, I'm still using the old act. So section 498, the equivalent act, the section in Bharatiya Nyaya Samhita, and the Protection of Women from Domestic Violence Act 2005, which I was talking about previously, and IPC section 304B. When a woman commits a suicide because of domestic violence, they can be booked under section 304B. And if they commit murder, they will be booked under section 300 and 302. So this Dowry Prohibition Act came in 1961 to deal with the cases where domestic violence is because of dowry harassment. Even otherwise also, the dowry, whenever there is a dowry demand, they can be addressed as per this act. And Dowry Prohibition Act is a civil act, but it can be combined with abatement for suicide or homicide whenever there is homicide or suicide in the victim. And the specific code which talks about cruelty is IPC section 498A. And here they says that women can file a criminal complaint against their husbands and husbands' relatives for any cruelty suffered at their hands. And this is a cognizable and non-bailable offense. They cannot get the bail in ordinary circumstances, and no need of a warrant to arrest these people, these offenders. And cruelty refers to any conduct that drives a woman to suicide or causes grave injury to her life or health, mental health included, and also includes harassment in the name of dowry. So all these cases can be booked under 498A. And coming to the Domestic Violence Act 2005, it is a civil law actually, but we can also put criminal cases when the victim is willing to go ahead with criminal cases also. And it protects women, married women, or also women in live-in relationships. Nowadays, live-in relationships have become very, very common, and sometimes there will be long-term live-in relationships. In such relationships also, if a woman is suffering because of the violence of the partner, she can also take the help of Domestic Violence Act. And this act imposes positive obligations on the state to protect women from violence. So this is the state's responsibility to protect the women. And the state is required to provide police officers with periodic sensitization and awareness training on domestic violence issues. And it also empowers the state to pass protective orders that the police must enforce. These things I'll be talking in the next few slides. And there will be special officer like protection officers assigned to assist domestic violence victims in obtaining medical care and in the filing of domestic violence reports. These are the special officers appointed for this purpose of domestic violence specifically. So what is the procedure to follow if you come across a person with domestic violence? First thing is to inform protection officer appointed under section 8(1). Any aggrieved person can report the incident of domestic violence to the protection officer appointed by the state government. Any aggrieved person, or sometimes if the aggrieved person is not willing to go ahead, we can also inform protection officer on their behalf. And report by protection officer. Upon receiving the complaint, the protection officer shall submit a report of incident to magistrate and station house officer concerning claim relief if aggrieved person desires. So if aggrieved person wants some claim, then they can produce this notice and complaint to the magistrate and then get the orders. And a note to the concerned parties. Upon receiving a report or complaint, magistrate of first class shall direct the protection officer to notice all the parties, including respondents, within 2 days from the direction unless extension is given. So whenever there is a violence in a particular family, the protection officer can report the matter to the an aggrieved person can report the matter to protection officer, and the protection officer can report the matter to magistrate. So within 2 days, the magistrate should decide what the claim the aggrieved person is having and what she should have. So upon hearing the magistrate, if the magistrate is satisfied that the domestic violence occurred, then he can pass residence order, monetary relief, custody order, or compensation order. This I will talk about them in subsequent slides. And magistrate can impose following punishment: imprisonment up to a term of 1 year, or fine up to 20,000 rupees to the offender. And according to the Domestic Violence Act, the aggrieved person could be a wife or a partner who is there in the live-in relationship. And adoption, like say, for example, a woman has adopted a daughter, even that daughter can be an aggrieved person, or daughter-in-law or sister-in-law, or mother, sister, daughter, etc. So aggrieved person is not just aggrieved person is not just the wife, but can be anyone who is sharing the same household or the same domestic space. So one thing I want to clear here is only a female can be a victim of domestic violence, and only a female can take the help of this DV Act. A male person who is being harassed by the females cannot take the help of Domestic Violence Act. This is a gender specific act. This is only for the females, not for the males. And who is the respondent meaning under the Act? It may be any adult member who is or was in domestic relationship with the aggrieved person and against whom relief is sought by the aggrieved person, including the male member living in the live-in relationship. So any person who is committing this domestic violence is a respondent. So what are the rights of the women under the DV Act? The protection order means the magistrate can give an order to the victim and also to the offender not to disturb her, not to get connected to her, not to go to her or talk to her, and maintain restraint from her. That is called protection order. Or he can give a residence order where, say for example, a woman is living with her husband or in-laws and she doesn't have any home to go. Then he can issue a residence order. She has every right to stay in her house without getting disturbed by the other family members. And she can also be given goods or medical assistance and counseling. So this is part and parcel of Domestic Violence Act. If she is mentally damaged or mentally upset or having depression or anxiety, she should get counseling, and also if there are injuries, medical assistance. And also shelter homes should be provided to give her shelter, and free legal aid. So we see that according to Mental Health Care Act, free legal aid is available for persons with mental illness. Here in Domestic Violence Act also, free legal aid is available for the victims of domestic violence. And maintenance orders, if the woman is not earning, she doesn't sustain by herself, then maintenance should be paid by the partner. And restraining order, not to go and disturb her, and compensation and custody. So if the woman wants to keep the custody of the children, she should be allowed to keep the custody. So what is more important for a psychiatrist to know is the Section 7. So this is the duties of medical facilities which is given in Domestic Violence Act. If an aggrieved person or on her behalf a protection officer or a service provider. So a patient can come directly, or a protection officer can come, or a service provider. Anybody can request the person in charge of a medical facility to provide any medical aid to her. Such person in charge of the medical facility shall provide medical aid to the aggrieved person in the medical facility. So whenever there is a request from any of them, we should provide medical facilities and medical services. So what are the medical facilities? The aggrieved person or the protection officer or the service provider may make a request under Section 7 to a person in charge of medical facility in writing, clearly stating that the application is being made under Section 7. So we have to take the request in writing. And when a protection officer makes such a request, it shall be accompanied by a copy of the domestic incident report. So this is the most important report which is essential for lodging a domestic violence report. And provided that the medical facility shall not refuse medical assistance to any aggrieved person under the Act for her not having lodged a domestic incident report. This is very essential, but it doesn't mean that everybody should have a domestic incident report. If you say that I don't want to see you because you don't have a domestic incident report, that is not fair. So even if they don't have a domestic, this is called DIR. If they don't have DIR also, we should see the patient and give medical assistance. If no domestic incident report has been made, the person in charge of the medical facility shall fill in Form 1 and forward the same to the local protection officer. If the person is not making any DIR, then you can make on her behalf. And the medical facility shall supply a copy of the medical examination report to the aggrieved person free of cost. So this is the sample, this is the domestic incident report, which is otherwise called as DIR. So here the name of the complainant or aggrieved person or age, address of the aggrieved person, all that should be entered. And the characteristics of sexual violence, forced sexual, you should take anything, like whatever it is there, we have to take based on the complaints given, like sexual violence, verbal or emotional violence, or economic violence. All this should be filled as per the form. And then we should give some documents like medical legal certificate. If the person is having medical legal certificate, that should be attached, and doctor's certificate or any other prescription, all this should be attached. So, and what is the need of the woman? She needs protection under Section 18 or residential order or protection order or maintenance order, whatever she wants. She can tick any of it. And assistance, what they need, like they need a counselor assistance or police assistance or shelter homes or medical facilities or legal aid. The women can take any of the things which she needs. So coming to the eighth point, instruction for the police officer assisting in registration of a domestic incident report. If you see the B instruction, if the aggrieved person doesn't want to initiate criminal proceedings, then make daily diary entry as per the information contained in the DIR with a remark that the aggrieved person, due to the intimate nature of the relationship with the accused, wants to pursue the civil remedies for protection against domestic violence and has requested that on the basis of the information received by her, the matter has been kept pending for appropriate inquiry before registration of an FIR. So this is very clear. Like say, for example, the woman is not willing to lodge a criminal complaint. A police officer cannot force her to lodge an FIR. Even the same applies to the counselor also, or to the medical facility, in charge of the medical facility also. We cannot force her to book an FIR or lodge a criminal complaint. So it is absolutely the consent of the individual which is most important, and the decision of her is most important. And if any physical injury or pain being reported by the aggrieved person, the immediate medical assistance should be given. So this form, DIR form, should be signed by a protection officer or service provider. We also come under service providers also. And this copy to be forwarded to the local police station. And coming to legal provisions and the legal management of domestic violence issues, and coming to the psychological management. So I have said that there are certain risk factors for perpetration of domestic violence. So we need to address those risk factors. Say, for example, alcoholism or personality disorder or some kind of risk factors which are immediately addressed, can be addressed. And identification and management of those risk factors and providing support. And advocacy is also part of psychological management. That is the reason why we need to know the intricacies of legal intricacies, and also we need to advise and advocate what the best option for her, and treatment services for victims of domestic violence, and multi-agency working to strengthen medical and social responses to domestic violence. This is not a single person's job. Many people are involved, like counselors are involved, shelter home in charges are involved, special protection officers are involved, police are involved. So this is multidisciplinary working. And we need to screen whether the person, whether the individual is having partner violence or not. So it is we need to remember, this is a mnemonic called RADAR, RADAR. R stands for remember to ask routinely about partner violence. This is a routine practice, whether you're a victim of domestic violence, like that, we need to ask. And ask directly about the violence, then document. Documentation is very, very important. And Domestic Violence Act specifically mentions that any service provider should not be liable for anything which goes wrong. Like, for example, not anything, but like we are not liable if the person doesn't make any FIR, or she doesn't want to go ahead and give a police complaint, or she doesn't want to talk to the protection officer. We are not liable for that. And and even if we complain to the magistrate, we are not liable for that. Like, we are not made scapegoats for giving some information. And then comes assessment of safety, whether the victim is safe or not, and the referral options, where to refer, how to refer, when to refer, all that. And coming to the screening, what do we need to screen? One is domestic violence assessment, whether actually the domestic violence is happening, if at all it is happening, how risky it is, what kind of violence it is, and how much severe it is. All this need to be screened. And then danger assessment, how much dangerous the situation is, that is also very important to assess. And then assessment of suicide risk, and then the assessment of PTSD and substance use disorders. So which patients do we need to screen? We need to screen all female patients who present with symptoms or signs of domestic violence, like multiple injuries. You see multiple injuries on the body. Sometimes we see multiple injuries, and we question, those people say that my husband had a lot of suspiciousness on me. So whenever he suspects, whenever I say something, he will hit me. So there multiple times we see in our OPDs and IPD, a lot of issues like this. So when you see any injuries or any signs and symptoms of domestic violence, we have to ask them whether they are victims. And depending on the injuries and stages of healing, etc., we need to screen. And also we need to screen children who present with symptoms or signs of domestic violence, and patients with history of substance abuse by themselves or their partners. In both cases, we need to screen. They are high-risk groups. And patients with eating disorders, conversion disorders, chronic pain syndromes, prior history of trauma, in all these cases, these are high-risk cases, we need to screen them. So then now how to screen them? In private and safe environment, separated from accompanying persons. Sometimes the accompanying persons could be the offenders. So if we ask the direct question of domestic violence and related things, they might not answer. So always in private, we need to ask them separated from accompanying persons. And the presence of a female assistant is must while a male clinician is screening the female client. And use local language in a comforting and non-judgmental way. Direct, specific, and easy to understand questions are preferable. We must discuss confidentiality issues with the patient. Some people say that they are victims of domestic violence, but they don't want to reveal this matter to anybody else. So we need to discuss the confidentiality issues. The patient may deny abuse if she's not ready to deal with the situation. Proper documentation should be done. If the patient is, all these details should be entered into the case sheet or whatever document you are having, you have to enter all these details. And proper documentation should be done. And some do's and don'ts. Make screening a part of assessment. Every time it is better to screen the patients whom you think they are risky of being a victim. Then assess the nature, causes, context, and impact. So all this we need to do. And use gender neutral terms. Nowadays we see lots of patients like there is something like third gender, which is considered to be normal. So there will be a lot of live-in relationships amongst them. So it is better to ask gender neutral questions, whether your partner instead of using your husband. Okay, that kind of gender neutral terms. Somebody might be living with a transgender person, we don't know. So use gender neutral terms. And a strong therapeutic relationship should be used. And follow-up is very much essential. Just you take once and then lose the patient for follow-up, then it is not going to help them in any way. And inquire about support system, what kind of support system they are having, that we need to inquire. And ask if family members need any support, all that we need to ask. And some don'ts are mixing up with other assessments. Don't mix up with other assessments. Do domestic violence assessment. And forcing disclosure, asking, forcing, coaxing, or forcing them should not be done. And abruptly ending without ensuring safety. We have to assess the danger and also the safety. Unless we assure or ensure safety, we should not end the counseling session or inquiry, whatever you're doing. Don't end without ensuring safety of the person. And direct eye-to-eye contact should not be done because they feel very intimidated. And insensitive to cultural issues. We need to be sensitive to the cultural issues also. And assumption about psychiatric strengths. We need not, sometimes we think that this victim is very strong, she will not do anything, she will not commit suicide. Like that, we cannot assume. We need to talk, ask them directly. And these are some of the screening questionnaires. Physical victimization scales, like this is like Likert scale. Scratched me, slapped me, these kind of items are there. In sexual victimization scales are also available, like have you had sex play and how many times, fondling, kissing, forcing you, like that. And the psychological emotional victimization scales, like how often has he refused to talk to you. This is also kind of psychological abuse. Not talking to the partner is also a kind of psychological abuse. And try to control your money, try to control your activities, refuse to do things which you always wanted to do. All this come under psychological abuse. These are different scales, screening scales, which are available. And the other important thing we need to screen is danger assessment. This danger assessment is a widely validated tool that determines the level of danger. So if a person is coming with the issues of domestic violence, we should definitely mandatorily do danger assessment. And it is a 20-item scale, and yes or no responses will be there. For example, do you believe he is capable of killing you? If the person says yes, we need to take it very seriously. Does he ever try to choke you? Is he violently and constantly jealous of you? So all this, like if the answer is yes, then we need to be very, very careful. There are some red flags. Victims who experience these red flag signs are at increased risk of being killed or almost killed. So like controlling behaviors, where are you going, what are you doing, with whom are you, this kind of controlling behaviors. And escalation of violence, they become very, very violent. Or recent separation, this is one of the risk factors. Stalking behavior, like following wherever she goes, or stalking. Even digital stalking is also dangerous. Digital stalking means checking your mail, checking your Facebook, checking your Instagram posts, and then following you. This kind of stalking behavior is also dangerous. And jealous obsessive behavior, and threats to kill victim, strangulation or attempts to strangle, harms or threatens to harm or kill children, and access or use of weapons. When one person has used a weapon once, then it is a highly dangerous situation. And perpetrator, recently I have seen a video which is widely circulating in Facebook, where the couple are from Kerala, but they are living in United Arab Emirates. And the person was continuously kicking her to the point that she died. And eventually, when police caught him and questioned, he said that I love her so much, that's why I was beating her. This was the response. A very, very toxic relationship. And perpetrator threatens or attempts to commit suicide. And perpetrator drug or alcohol misuse, sexual assault, and threatens to harm or kill pets. Perpetrator unemployment and pregnancy or new birth. These are all the red flag signs. And the screening should, sorry. The screening should be done in a private, confidential space, and provide interpreters as needed. Discuss the reasons for assessment with your patients. It will reduce their fear, anxiety, and the risk of aggression. So directly don't jump into talking about domestic violence. First, tell the reasons why you're assessing. Like if you are putting danger assessment questionnaire, or the abuse questionnaire, first we need to make them understand, that is for us to understand the depth of the domestic violence. It will reduce their fear, anxiety, and risk of aggression. And describe with as much detail as possible what is happening or going to happen, which will increase a sense of control and decrease fear and anxiety. And debriefing technique should be used. Whenever they try to ventilate, we need to listen to whatever they are ventilating, and work with the patient on a safety plan, and focus on coping strategies. What all coping strategies the victim is having, we need to explore, and also give them options to exercise their coping strategies. And the therapies which are very effective are prolonged exposure therapy, cognitive processing therapy, eye movement sensitization therapy. These are all for PTSD, because the PTSD is the most problematic mental health impact. These are the techniques which are used. And interpersonal psychotherapy, when there is a communication problem between the offender and the victim, and if that is the cause for violence. And helping to overcome PTSD through empowerment, and cognitive trauma therapy for battered women. These are all some of the techniques, which I'm not going into details of that. One of the technique which is more effectively to be seen is Stair technique. Be used in PTSD, like Stair, evidence-based. This is a technique. Skill-based, skill-focused CBT for PTSD treatment. It is initially developed for individuals with PTSD related to childhood abuse. It can be implemented both in individual and group modalities. So if you can see narrative therapy, these are the eight steps in a Stair therapy. One is introduction to treatment. Week 2, they talk about emotional awareness. What I said in PTSD is they have a complicated PTSD symptoms. So the main important symptom in complex PTSD is emotional dysregulation, which can result in future. The abuse continues because of the vicious cycle of emotional dysregulation in the victim. So week 2 talks about emotional awareness of their own feelings, and what kind of frustration or stress or emotional dysregulation feelings they have. All this will be explored in week 2. And they will teach emotional regulation in week 3, and emotionally for week 4, emotionally engaged living distress tolerance. So how to tolerate the distress and all will be taught in week 4. And week 5, recognizing relationship patterns, what kind of relationship patterns they are having, like dominating kind of partner, or what kind of partner, and how to deal with their own emotions. And week 6 and 7, changing relationship patterns, and week 8, self-compassion and grief. These are the different steps in Stair technique. And another thing is interpersonal psychotherapy, when there is a communication difficulty between the partners. I'm not going into the depth because every one of us know about this. So they have different areas. Here in PTSD and here in domestic violence, the most important thing is interpersonal relationships, how to address these communication difficulties. And one more important therapy is cognitive processing therapy. Cognitive processing therapy is very helpful in educating the victims about PTSD symptoms and the effect of traumatic events, what effect they are having because of the trauma they are facing, and the connections between trauma related thoughts, feelings, and behaviors. Any trauma is associated with a thought, and the thought is associated with the feeling, and the feeling with the behavior. So these connections we need to establish, what trauma is causing what kind of thoughts, what kind of feelings, and what kind of behavior. So we have to establish that connection, and remembering the traumatic event and experiencing the emotions associated with that, and the ability to challenge maladaptive thoughts about the trauma. And if the victim is thinking that I cannot survive with this trauma, or I don't have any supportive system, all these kind of cognitive distortions need to be addressed. And reduction of negative thinking patterns, and motivation to learn new healthier ways of thinking, and exploration of how core themes have been impacted by trauma. All this is called cognitive processing therapy. So with this, I'll end my presentation. Recovery is a process. It takes time and it takes patience, and sometimes it takes everything you have got. Thank you so much for patiently listening to me, and I think I have covered everything related to this topic. I thank everyone.
Thank you so much, dear Dr. Anita Madam, for a very detailed, insightful, thought-provoking session. So your slide read, real men don't hit women. Few things that you highlighted, like cycle of abuse, physical and psychological impact on account of domestic violence, routine screening that is required by all of us towards our patients, red flag signs, do's and don'ts, where I'm very sure that all the attendees would agree that you have provided a very detailed insight onto the topic. Thank you very much, madam. I would now request Dr. Shivaraman sir to provide few insights on this topic. Dr. Shivaraman sir.
Good evening, madam. Am I audible?
Yes, sir.
Yeah, and Dr. Anita ma'am has done an extensively very good presentation. She has involved, almost included all the important informations. Very thank you for your kind, wonderful presentation, ma'am. Actually, to add some of the information, so domestic violence it can be interchangeably used as a synonym as intimate partner violence. That madam has already informed. The Elizabeth 2008, actually, she tried to say the domestic violence not only include the conflict between husband and wife, it can be something a heterosexual relationship, or it can be same-sex relationship, or between the former spouse or partners. So there is some expansion of the domestic violence has been, some school of thought says it is some more expanded one. Though we could able to see men against the wife or female companions are the actually a larger group require this label of domestic violence. There are very few cases of reverse also. That is one information. Regarding the forms of domestic violence, ma'am has nicely informed about physical abuse, sexual abuse, psychological abuse, and economic abuse. And this clinical practice guideline given by Dr. B.N. Ravesh in our published in our Indian Psychiatric guideline itself, they have talked about another interesting fact about an abuse called spiritual abuse, where the partner is forcing or deviating the spiritual beliefs of the partner. That also has been mentioned as one of the form of abuse. That is one thing. When we were trying to understand about the epidemiological part of the domestic violence, some interesting threes are there. Like 1/3 of the women around the world found to have suffering from this domestic violence, and 2/3 of the women found to have some or other psychiatric issues, mental disorders, and 1 in 33 means every 33 minutes there is one person having this domestic violence issue. So these are some interesting factor. And the first person who we need to train is medical practitioners rather than psychiatrists. The medical practitioners need to be trained more because they are the mostly first professional who come into contact about on this domestic violence. So we need to train them more. Actually, this particular Ravesh et al. Called for a proper medico-societal legal environment should be there, because almost half of the women are suffering from this issue. So he calls for a medico-societal legal environment. So some connections between all these three things should be there so that we could be able to help better the aggrieved persons. And also there were some theories of this domestic violence. There were 3 proposed theories for this domestic violence. One theory is this is occurring because of frustration. Because of frustration, this violence is occurring. That is one. The second is it is occurring as a response to immediate conflict. There is an immediate conflict, and because of that, this is occurring. That is number 2. Number 3, it can be an act of a criminal act. So there are 3 different theories has been proposed on this thing. Regarding legal aspects of this domestic violence, 3 main acts are very important, which is already has been described. That is Dowry Prohibition Act, then Indian Penal Code Section 498A. These 2 mainly comes under a criminal act. There is another act which Madam has detailedly informed is this PWDWA Act, that is Protection of Women from Domestic Violence Act 2005. The beauty of this act is that is one thing is it is a civil. The other thing is it actually specific mention about the person in live-in relationship also, not only the wives. Live-in relationship persons also can use this act. That is one extra information that we can say. And after once these acts has been under follow, there are many interesting cases which has been mentioned. This domestic violence law in India, this Ravesh et al. In Indian Psychiatric Society, he has given some 3-4 famous legal cases which I think worth reading. Okay, some quick information on this is, one main information is when you are applying this Domestic Violence Act, the domestic relationship must be established. That is, the partner as well as the person who abused should be in the same domestic place. Then only it can be applied. That is one thing. Why this has been informed is, if the person is divorced, they cannot apply this law. That is one thing. If the person has gone out of the house, then after that this cannot be applied. So like this, these are some of the loopholes that need to be checked before using this act. Then again, after seeing there are many misuse of this act, they have created a committee, mainly the Sapneshwar degree in the means because of a case in Orissa. So they have given a guideline that a family welfare committee should be formed for every case before arresting a male or any abused person. So some immediate arrest has been stopped. Some sort of inquiry has to be done before arresting. That is one thing. And instead of they have removed the word adult male from that from in the act, and because that is very because there are sometimes even women's also be a means abuser, so that they have done. So these are some of the informations. Though the three main act has been discussed detailedly, there are some other acts that is also helping regarding this domestic. I mean, not directly, but it is helping the women in this area. That is Hindu Succession Act is there. Okay, it gives a equal right for both male and female. That is one thing, and that is another act called the Equal Remuneration Act is there. Okay, so that both male and female should have the same salary if they are working. That is one act it is helping. And there is a law against sexual harassment at the workplace that is there. So these are some of the things, though directly not involved in domestic violence, but it is also helping. These are some of the informations. But otherwise, madam has given very nice about how to assess and how to treat and all those things. Even madam was gives out do's and don'ts while we are assessing the person with domestic violence. And she has given the mnemonic of radar. That is a famous thing when you are assessing that she has given. Okay. When we are trying to manage the patients with the Domestic Violence Act, most of the times the female or the wife won't give the information to us, though we are providing the safe and secure environment. Three main reasons has been reported of mainly for this. One thing, she may feel that it may cause more harm if she is giving the information, and she feel embarrassed. Number three, economic problem. So these three factors has to be addressed before we are means assessing the domestic violence person with the domestic violence. So all these things has to be keep in mind. Okay. And for PTSD also, there is one another mnemonic called HOPE, HOPE. HOPE is helping to overcome PTSD through empowerment. H, helping to overcome. P for PTSD through empowerment. So these are some of the mnemonics that need to be kept in mind. Okay. There are some helplines also given that can also be a part of the presentation. Okay. Like 1091 is one helpline. There are many helplines given in the article. And otherwise, actually, it was a very thoughtful and eye-opening presentation. She has started with the clinical vignette and given the many informations. Actually, I would like to thank the Indian Psychiatric Society South Zone branch for providing me this great opportunity. As well as I would like to thank the Women Empowerment Committee members, every person, especially Professor Veda ma'am, for giving this opportunity to learn and to be a part of this great gathering. Thank you for your
Thank you, Dr. Shivaraman sir, for your added information on the topic. So I think I have a few questions that I see in the chat box. Can we just take up one or two questions from the chat box, ma'am, Anita ma'am?
Yes, ma'am. Yes, ma'am, sure.
Yeah. There's one question which says, thank you for the wonderful presentation, madam. Rightly pointed out that women with mental illness are the victims more often. When a woman with severe mental illness accuses the husband and family members, is there any time frame to ascertain the facts and report the domestic violence for the HCP?
Yeah, it is a very difficult situation because we don't know whether they are acting because of delusions. Many a times during delusions, they say that my husband is exploiting me, he's having an affair, all these kinds of things. But when we assess, we know that it is a case of delusional disorder or a paranoid schizophrenia, or sometimes could be borderline personality. So when we assess if we have clear-cut symptoms of psychiatric illness, first we need to treat them till all the delusions and then the hallucinations have come down. And also the signs of harassment like physical injuries. We have to examine the physical injuries. We can interview the family members, like immediate like a mother or father of the victim, and then try to get some information from all these sources. If we have high index of suspicion, then we can go forward. But if we think that it is just because of a mental illness, then we cannot go forward. Yeah.
Thank you, ma'am. There's one more question. They want to just know what is the likely percentage of psychiatric illness in persons with domestic violence?
Yeah, as I said, the most common thing is PTSD. 50 to 90% of the patients had reported PTSD. So it's like almost more than 50%, I can say, based on the burden of psychiatric illnesses. Most commonly PTSD, and then depression, suicide, and anxiety, substance use disorders. These are the common psychiatric conditions we see. But in India, these prevalence of mental illnesses, these studies are not very much there. They're lacking. Yeah, one thing is what we reported, what we are seeing are reported cases, which are the tip of iceberg. Many cases go unreported, many don't come. Even if they report, they don't want us to, inform the police. So there are lots of things and intricacies in reporting. So this is not an actual picture. This is only a tip of iceberg. There would be many cases which are victims of domestic violence. But if the patient doesn't want to report, so we have to assess the risk and benefit. If the patient is seriously ill or having severe injuries, grievous hurt, or she is suicidal, extremely suicidal, then we need to breach the confidentiality and inform the police. If the patient is not having serious domestic violence issues, and if she wants to not to report the case, then we cannot force her to report, or we need not report. But we have to document in the documents that she is a victim of domestic violence, and she wanted to keep it confidential. That we can write in our case sheets. We can breach the confidentiality, suicide, harm to herself, or harm to others like children. In those cases, we have a mandatory reporting thing. Otherwise, Domestic Violence Act doesn't say that we should mandatorily report each and every case. That is not there in the Act.
Okay, ma'am. Thank you for your insights. Are there any more questions from the participants? If so, please post it in the chat box, or you can unmute and directly ask madam.
Shall I ask a question to ma'am to have an idea?
Yes, sir. Please go ahead, sir.
Ma'am, actually, Manita ma'am, when we are trying to, for example, we find a person with a psychiatric illness or alcohol issue. Sometimes I used to say to the spouse that this person is repeatedly beating you, repeatedly means in spite of your best effort, he is again taking alcohol. So why do you want to be with him? Like that I have asked to just to know what is their understanding. But most of the time, the person, for these spouses only, these acts are being given. But I could say that most of them are not, even if you are trying to give the awareness, they are not using those acts. What is your idea? Because when I talk to them, they say that, sir, why you are saying these things? I want my husband. I want to be with him. Even if he beat me, he is my husband. All those things they are saying. So what is your experience on this area?
Same kind of experiences I do have. Many a times they don't want to, leave the husband or put a case on him or go to the court and all. So as I said before, that is one of the risk factors, enabling behavior. So who tolerate more get more. So people they are enablers, and particularly more so in alcoholism. And because of that, honeymoon phase could be like after a while, after the abuse, the partner becomes extremely soft and extremely loving and caring. So that is the reason why might be they put up to him. And the other factors like emotional support and financial support. And recently, I have seen a case where the the wife of a husband who came for psychiatric help. He's having looks like having bipolar disorder, and the first child, who is 13 years old, committed suicide because allegedly, she says, could be because of his sexual behavior with her. She might have committed suicide. That is the wife says. But when we asked her to put a complaint, she said blatantly, she said, I don't want to complain. How can I live? He's the sole breadwinner of the family. I'm having a small kid, and family members are not supportive. So how can I go against him and give a complaint? In spite of losing, one child for suicide, she doesn't want to come out. So there will be a lot of factors. It could be multifactorial. We cannot under each case by case. If we see, there will be different factors. So bottom line would be many people want to tolerate, particularly in our Indian setup, where marriage is considered to be sacred, and
Yes,
at
ma'am.
no point
Apart
we
from
should
this,
leave the partner and cultural beliefs.
that is the cultural beliefs and the societal pressure to stay with the husband, even
Cultural
if
beliefs.
those also plays a role. Yes, ma'am.
So
Yes, sir. All these
I think
factors
there are not
multifactorial.
no questions anymore seen in the chat box. So on behalf of everyone here, I would like to thank you for being a voice, ma'am, for those who are often unheard. So your words today will surely echo in our minds and actions going forward. Thank you so much for the wonderful presentation and sharing your personal experiences with the patients that you came across. Thank you, Dr. Shivaraman, sir, also for your detailed insights on the topic. Now, may I request Dr. Abhirami to kindly deliver the vote of thanks.
Good evening, ma'am. Good evening, sir. Women Empowerment Committee, South Zone. On behalf of Women Empowerment Committee, I extend my heartfelt gratitude to the IPS President, sir, IPS President-elect, sir, South Zone President, sir, Secretary, sir, and other members of South Zone and office bearers for their unwavering support in organizing this webinar. And special note of thanks to our esteemed speaker, Dr. Anita, ma'am, for her excellent and insightful presentation on the important topic of domestic violence. I also sincerely thank the chairpersons, Dr. Vijayalakshmi ma'am and Dr. Shivaraman sir, for their valuable opening and concluding remarks, which framed the session meaningfully. I would like to express heartfelt thanks to Dr. Veda ma'am, our convener, hosting this session very excellently, and to the dedicated members Niveda ma'am, Aruna ma'am, Uma Jyoti ma'am, Elsie ma'am, and Indu ma'am for their consistent efforts behind the scenes. My sincere thanks to all the participants whose active presence made this event a grand success. Lastly, we extend our thanks to East Swama for partnering this event with the Women Empowerment Committee South Zone. Once again, thank you all. Thank you, ma'am.
Thank you so much, Abhirami. I think we can conclude the webinar. I hope it has served the purpose for many of us who have attended this webinar. Thank you once again, dear chairpersons and speakers, and our dear colleagues who joined the webinar. Thank you so much.
Thank you.
Thank you very much.
Thank you, Dr. Anita, Dr. Vijayalakshmi, and Dr. Shivaraman, sir. Thank you, Veda.
Thank you, ma'am. Thank you so much.
Thank you, Veda. Madam,
Thank you,
madam.
sir. Thank
Veda,
you, sir.
thank you.